Hey, good afternoon, everyone. And thank you for attending the second of the two-session webinar on pathology. This afternoon's lecture will cap the 6-week virtual interdisciplinary conference spearheaded by the Committee on Training Program of the Philippine Society of Gastroenterology. To formally start this afternoon's conference, may I please ask one of the members of the Committee on Training Program, the foremost expert on achalasia and peroral endoscopic myotomy in the country, Dr. Grace Santi, to lead us into prayer. Dr. Santi.
Let us all remember that we are in the most holy presence of God. In the name of the Father, and of the Son, and of the Holy Spirit, amen. Heavenly Father, as we gather here in the harbor of your safety, we come in gratitude, giving thanks for fellowship and friendship. Guide our speakers, give them clarity of thought and communication, so that they may deliver everything that you laid on their hearts to speak about. Bless and guide all of us who join this afternoon's meeting as we delight in learning things they have to teach us. Please bless the efforts of our hands and the influence of our work always. Lead us so that our GI fellows may reap the benefits of our collective wisdom and experience. As we plan and share together, may you guide us by your Holy Spirit and lead us into all truth. This we ask in Jesus' name. Amen. In the name of the Father, the Son, the Holy Spirit. Amen.
Thank you very much, Dr. Grace. And once again, thank you to everyone for joining us this afternoon, and most especially to those who have joined us since the very first Saturday of this webinar series. Okay, so for this afternoon, we will look at the program. Okay, so we will be after Dr. Galang's welcome remarks in a while, we will be discussing the pathology of the liver and the pancreas. And this afternoon's lecture will be given by Dr. Marife Bonifacio. This is again the second of the two-part pathology lecture series. So for some basic house rules, right? So everyone will be on mute when you join the session, and it will be like that up to the end of the conference. Next slide. It is encouraged that you use two-way microphones or earphones to have a clearer audio and to minimize the audio interference from your location if you will be given the chance to use the microphone. Next slide. The lecture will be delivered using a PowerPoint presentation for everyone to see. It's going to be controlled by the speaker herself and aided by the host when needed. And lastly, we encourage everyone to participate in this afternoon session. You may do so by typing in your questions at any point of the discussion in the Q&A box, and we will be entertaining these questions every after a topic is done. During the Q&A portion, every other topic, every after topic, we will also allow some who may want to raise their hands and use the microphone to ask their questions. So you can raise your hands then and we will acknowledge you. Okay, so the interdisciplinary conference has been conceptualized to help augment the training of GI fellows in this time of the pandemic, but we are very happy to have seen the positive reception coming from the consultants as well. We hope that the last 6 weeks of conferences on GI radiology and GI pathology had further deepened our understanding of the common GI conditions that we see in our clinics. So these are the topics that we have discussed over the last 6 weeks. And again, my sincerest gratitude to those who have stayed from week 1 to today. Okay, so to formally welcome the participants to this afternoon scientific forum, Let me call on the dashing president of the Philippine Society of Gastroenterology, whose intensity matches the rains today over Quezon City, Dr. Augusto Jose Galang, for his welcome remarks. Dr. Galang.
Thank you very much, the ever indefatigable chair of the Committee on Training Program of the PSG, Dr. Romel Romano. And I would like to welcome everyone to this virtual interdisciplinary conference. As what Dr. Romano has mentioned, this webinar series is an adaptive response by the Philippine Society of Gastroenterology to help in the cognitive development of our training fellows. However, this webinar is also offered to all members of the PSG, young and old alike, so that we may have the opportunity to revisit and review concepts in GI pathology. Especially this afternoon, we have our able speaker from the Philippine Society of Pathologists and an equally able moderator for today. So without further ado, I would like to give the floor or the microphone back to our host, Dr. Romel Romano. And thank you.
Thank you very much, Dr. Galang. Okay, so without further ado, I would like to introduce the moderator for this afternoon. The moderator for this scientific session this afternoon is a fellow Thomasian. He graduated from the University of Santo Tomas Faculty of Medicine and Surgery, and he had his fellowship training in gastroenterology and digestive endoscopy from the UPPGH. He is the fellowship. He had his fellowship training in general hepatology and liver transplant medicine in the A.W. Morrow Gastroenterology and Liver Center in Sydney, Australia. He is a past training officer of the Department of Internal Medicine at the NKTI and a past president of the Hepatology Society of the Philippines. It is my pleasure to introduce Dr. Jade Jamias. Dr. Jamias.
Thank you, Dr. Romano, for that introduction, and good afternoon to all of you. So it's actually a great privilege also to introduce our resource speaker for this afternoon's conference. So she is a graduate of the University of the East Ramon Magsaysay Memorial Medical Center and had her residency or finished her residency training in anatomic and clinical pathology at the St. Luke's Medical Center and move on to have her fellowship training in gastrointestinal and hepatobiliary pathology at the University of Washington Medical Center. She is an active member of several medical societies and currently an assistant professor 1, both at the Department of Pathology and Department of Biochemistry and Molecular Biology at the St. Luke's William Quasha Memorial College of Medicine, and currently the training officer of clinical pathology in the same institution. Friends and colleagues, please help me welcome our resource speaker for today to talk about the pathology of liver and pancreas, Dr. Marife J. Bonifacio.
Good afternoon. Thank you, Dr. Jamias, and to Dr. Roman and Dr. Galang, and to the committee in charge for this webinar. Thank you for inviting me and for the opportunity that you have given me to share my expertise and knowledge in the field of hepatobiliary. So for this afternoon, my goal is to discuss the basic pathology of hepatobiliary system, specifically to discuss the normal histology of the hepatopancreaticobiliary system, to discuss the histopathologic findings of the commonly encountered diseases of Pancreatic biliary system, and to discuss some ancillary tests such as immunostains and special stains used in the diseases of the liver and the pancreas. So the flow of my lecture will start first with the liver, followed by the pancreas. So for the liver, we will begin with the non-neoplastic or medical liver, followed by the neoplastic liver. So basically, when looking at a liver biopsy, whether medical or neoplastic, we are taught to first and foremost assess the adequacy of the biopsy. So, and secondly, we assess the architecture or cytology if the biopsy is normal, and sometimes we use immunohistochemical stains to help us get an accurate diagnosis. So how do we know, or how do we determine if a liver biopsy is adequate? So according to American Association for Study of Liver Diseases, the recommended width is 16 gauge with a length of 20 to 30 millimeters, with 11 or more portal tracts are desirable. However, this depends on the situation. If one is dealing with a malignant diagnosis, even if it is a limited material, it is considered sufficient. So also, if one is dealing with a transplant recipient, then there are strict criteria of the number of portal tracts, whether to say the presence or absence of acute or chronic rejection. So basically, the more tissue one has, the better. Now, if we open a chapter or a textbook in liver pathology, we see pictures like this, and we are told that the liver is made up of hexagonal lobules, where the portal tracts are at the periphery, and the central vein is at the center. So we are also told that by Rappaport that the liver is organized into acini. They look like cluster of grapes, and they are divided into 3 zones. Zone 1 closest to the portal tract, and zone 3 closest to the central vein. However, whenever we receive a liver specimen, the hexagonal lobules are not that prominent. However, but the portal tracts are distributed at irregular intervals. The central vein is also most of the time not at the center, but we see them surrounded by these regularly distributed portal tracts. So for this discussion, I will be using the term centrilobular for the hepatocytes that surrounds the central vein, and periportal for the hepatocytes that surrounds the portal area. So centrilobular also corresponds to the zone 3 area, and for the periportal it also corresponds to zone 1 in Rappaport system. Now with liver core, the hexagonal lobules are more difficult to appreciate. So what you see is a big sea of pink because of the extensive amount of hepatocytes, punctuated at irregular intervals by portal tracts and central vein. So I am emphasizing this because the distribution of the portal tracts in neoplastic process or in focal lesions such as hepatocellular adenoma or FNH is altered. Also, the vague delineation of the hexagonal lobules is partly because the liver has very limited fibrous tissue. So fibrous tissue is usually stained. We use trichrome stain to demonstrate the deposition of fibrous tissue in the liver. So basically, the normal should be a thin amount of fibrous tissue in the portal tract and in the central vein. So this is what a normal trichrome stain looks like. Whenever we see that this blue stain expands, then we think of progression of the disease. Basically, the fibrosis is expanding from portal area, forming a septa, to bridge with another portal tract. Now, unlike the tubular GI tract, which has the mucosa, the submucosa, the muscularis, and serosa, in liver, we usually assess by compartments. So the compartments that we assessed for are portal tracts, lobules, and sinusoids, and central vein. So first is the portal tract. So the portal tract is a well-delineated structure that abuts the limiting plate. So the first layer is the limiting plate. The limiting plate is important because it is where the regenerative nodules are found. Also, it is where the progenitor cells are found, and whenever lymphocytes are recruited in the portal tract, whenever it spills over this first layer, we call it interface hepatitis or piecemeal necrosis. So these are evident in some diseases in the liver. There are three structures that are found in the portal tract. So first is the portal vein. Portal vein is a thin-walled structure, the largest of the three structures found in the portal tract. So basically, portal vein has a thickness similar to the central vein. So it's 4 times the size of the hepatic arteriole. The second structure in the portal tract is the hepatic arteriole. The arteriole is comparable in size with the bile duct. So whenever you have arteriole, almost always it is paired with a bile duct. This is so because the bile duct, the blood supply of the bile duct comes from the arteriole. So I am mentioning this because whenever an arteriole is seen without bile duct, we call it unpaired arteriole. And unpaired arteriole are noted to be increased in lesions such as hepatocellular adenoma or hepatocellular carcinomas. The last of the structure is the bile duct. So bile duct is described to be string of pearls in appearance or rosary beads because the nuclei are evenly spaced. So this one, I'm emphasizing the structure because in diseases such as biliary cholangitis or primary sclerosing cholangitis, the bile is usually damaged and injured, and the normal evenly spaced nuclei is not appreciated. So what we see are vacuolizations or reactive changes. So also, 38% of the time, the portal tract doesn't have any portal vein. So it will only be portal dyad. Next, the bulk of the liver are the lobules, which contain the hepatocytes. So basically, hepatocytes are centrally located. They should have minimal or fair amount of eosinophilic cytoplasm. Also, the architecture of the liver should be one cell layer. I'm emphasizing this because in malignancies, such as the hepatocellular carcinoma, the one cell thick layer of hepatocytes is usually altered. So this layer is demonstrated by the reticulin stain. Now, reticulin stain will stain the type 3 collagen, which is a normal component of the liver. So it will appear like this in the picture in the left lower. Reticulin will stain the one cell layer of hepatocytes and will stain the portal tract and the central vein as well. Also found in the sinusoidal area are endothelial cells and some lymphocytes. So these are normal components of the liver. Now, knowing the normal architecture and the normal cytology of the liver, the immunohistochemical stains that we use to support the lesions that we see are the following. So basically, we have special stains, mostly used in medical liver, and we have immunohistochemical stains, mostly used in tumoral lesions. So for special stains, routine stains that we order are reticulin, trichrome, and iron stain. Reticulin, as I've mentioned, it is used to demonstrate the type 3 collagen and to demonstrate the normal reticulin framework of the liver, while trichrome stain is used to stain type 1 collagen. So basically, trichrome is used to, also someone's raising. Basically, trichrome is used to stage the disease or to demonstrate the fibrosis. Iron will be used to demonstrate excessive iron deposition such as hemochromatosis or hemosiderosis. And PASD corresponds to periodic acid shift with diastase, which is used for demonstration of eosinophilic globules in alpha-1 antitrypsin deficiency. So for the immunohistochemistry, what we used are hepatocytic markers, which are Hepar1, Glypican-3, and Arginase-1. So basically, we use 2 markers for the hepatocytic and 2 markers for the other malignancies that you're considering. Like for example, if we're considering an adenocarcinoma or a cholangiocarcinoma, we request 2 hepatocytic markers and 2 cholangiocytic or stains that will be positive for adenocarcinoma. So for the poll questions, which of the following is a typical histologic feature of autoimmune hepatitis? Okay, so the answer for this is all of the above. So we will discuss the histologic features one by one in the next topic. So basically, we will start with medical liver biopsies. So usually these are non-specific as the liver has the same appearance for many mechanisms of injury. So to simplify, our approach in medical liver is compartment-based or based on the predominant pattern of injury. So my lecture is divided into 6 parts based on the predominant pattern of injury. So as I've mentioned, the compartments that we usually assess for are the portal tracts, the central vein, and the lobules. So our first pattern of injury is portal inflammation. Portal inflammation is probably the most common, the observed pattern of injury in the liver. So basically, if this is the normal portal tract, what is acceptable is just minimal amount of inflammation compared to a predominant pattern of portal inflammation that lymphocytes, mononuclear cells infiltrates this area, the connective tissue of the portal tracts, and sometimes, if severe, it will spill over the first layer of the hepatocytes. And that's what we call the interface hepatitis or piecemeal necrosis. So basically, portal inflammation is the defining feature of chronic hepatitis of any cause. So unacceptable inflammatory infiltrates in the portal tract should be minimal and not aggregates of mononuclear cells. So there are several disease entities that will present with portal inflammation. So I will be discussing 2, which are the most commonly observed in practice. So first is viral hepatitis and second is autoimmune hepatitis. So in this picture, it is evident that the injury is more predominant in the portal area. So these are the portal areas encircled in red. So it should be minimal or dot-like inflammation, no aggregates of lymphocytes. But in this slide, what we see are blue aggregates. These are all mononuclear cells that infiltrates the portal tract. We know that this is a portal tract because there is bile duct, hepatic arteriole, and portal vein. Also, aside from the portal inflammation, what we see are scant amounts of lobular inflammation pointed in the arrow. So this is an example of a portal predominant pattern of injury, portal inflammation. So for our first disease entity, which is viral hepatitis, this is a microscopic picture of a core from a patient with viral hepatitis. So here we see blue aggregates, which are lymphocytes and few plasma cells that infiltrates the portal tract. So if you look at it in higher power, you appreciate that it is lymphocytic in predominantly. Also, aside from the portal base, as you can see, these lobules, the hepatocytes, are less inflamed. Actually, very scant or rare foci of lymphocytes are seen. In severe cases of viral hepatitis, so this is the portal tract, the lymphocytic infiltrates may spill over the first layer of hepatocytes, and this is what we call interface hepatitis. So, interface hepatitis, regarding the question, is a non-specific finding and can also be found not only in autoimmune hepatitis, but also in cases of viral hepatitis. Although it is variably found or not extensive in nature, but it can be found in viral hepatitis. Also, as I've mentioned, aside from the portal inflammation, since there are rare foci of inflammatory cells in the lobules, there are times that hepatocytes can undergo apoptosis. So, ang apoptotic body, also called acidophil body, it's rare foci of hepatocytes that undergoes apoptosis. So, it will demonstrate eosinophilic cytoplasm and a little bit of smaller nuclei. In some cases, there are features that will tell you that you are dealing more with hepatitis B than hepatitis C. So for hepatitis B, the hepatocytes show characteristics changes such as ground glass cytoplasm compared to the previous picture that I've shown you where the cytoplasm is lighter, not dense like this. And the nuclei will show changes such as it becomes more purple or sanded or more clear compared to the usual nuclei. So this is because of the Hep B surface antigen and hepatitis core antigen. So basically, these findings are not always seen in Hep B, but when seen, it will usually support the diagnosis of hepatitis B. So take note that these findings are not seen in hepatitis C. In hepatitis C, what we usually see are portal inflammation that has germinal centers. So this is a bile duct encircled in red, surrounded by severe inflammatory infiltrates that has areas of interface hepatitis. Also, aside from the lymphocytic or the germinal centers that we see in hepatitis C, a predominant feature is the presence of macrovesicular stetosis that surrounds the portal area. So this macrovesicular stetosis, in comparison to NASH or ASH, is portal-based. So in NASH, the macrovesicular stetosis is usually found in the zone 3 area or in the centrilobular area. So again, the lobular inflammation is less compared to the portal inflammation. So this is important because in autoimmune hepatitis, lobular inflammation is extensive as well. Almost the same with the extent of inflammation seen in the portal area. So these are the key histologic features of chronic viral hepatitis. It's a predominant portal-based injury, mostly composed of lymphocytes. If we see lobular inflammation, it is less prominent compared to the portal inflammation. And these features that will usually, soft features that will support diagnosis of either Hep B or Hep C. So basically, in practice, these are not biopsied, but serologic tests are the gold standard for the diagnosis. So if ever a biopsy for chronic viral hepatitis is done, the role of liver biopsy is to grade the disease or stage the fibrosis. For the next major disease entity that will present with portal inflammation, usually autoimmune hepatitis has very similar in appearance or same morphology with viral hepatitis. The difference is that autoimmune hepatitis has more plasma cells in the portal inflammation. So in chronic viral hepatitis, lymphocytic infiltrates is more predominant, while in autoimmune hepatitis, there is overrepresentation of plasma cells. Next, the second picture, there is extensive inflammation, both in the portal tracts and in the lobules. So in this picture, you can't even delineate anymore which one is the portal tract and which one is the centrilobular area. But basically in autoimmune, you have more plasma cells and the extent of lobular inflammation is as severe as the inflammation seen in the portal area. Sometimes there are features that we see that will help you lean more towards the diagnosis of autoimmune hepatitis. So these are hepatocytic rosettes. Basically, these are a group of hepatocytes that will show you central lumen because of the dilated canaliculi. Next is Mperipolasis. Mperipolasis is a non-destructive engulfment of hepatocytes, of inflammatory cells by hepatocytes. So basically, we see lymphocytes within the cytoplasm of hepatocytes. Whenever we see these are soft clues that we are dealing with autoimmune hepatitis. So for the poll question a while ago, the features of autoimmune hepatitis include all of the choices mentioned. So basically, the portal inflammation is plasma cell rich with prominent interface hepatitis and piecemeal necrosis. So meaning it's extensive compared to viral hepatitis, which has variable focus of interface hepatitis. The lobular inflammation is often severe compared to viral hepatitis. So both portal and lobular inflammation is severe, and other features are Mperipolasis, hepatocytic rosettes, and syncytial hepatocytes. So again, just like viral hepatitis, fibrosis starts in the portal tract. So basically, autoimmune hepatitis cannot be adequately diagnosed by biopsy alone. It should be in combination with the clinical presentation, with serology, which will show you elevated IgG levels and elevated anti-nuclear antibody or anti-smooth muscle antibody or liver-kidney microsomal antibodies. So aside from serology, this should be supported by biopsy, which will show you, as I've mentioned in my previous slide, the histologic features of autoimmune hepatitis. So our differential for portal-based, portal inflammation predominant pattern of injury are the following. So in viral hepatitis and in autoimmune hepatitis, the predominant feature will be portal inflammation, viral, usually lymphocytic, predominant, autoimmune hepatitis, plasma cell predominant. Drug injury, it will depend on the drug that it has been taken by the patient, but most of the time, these drugs are associated with portal inflammation as well. In Wilson's disease and alpha-1 antitrypsin deficiency, most of the time will present with portal inflammation, but Wilson's disease have extremely variable, more microscopic changes. So making this disease entity difficult to categorize based on histologic pattern. So this will be further discussed in the steatotic pattern. So those are the disease entities for portal inflammation. The second pattern of injury is the lobular changes or the predominant lobular injury. So basically, this is the area involved, so away from the portal tract. So normally, lobular changes is found admixed with other patterns of injury, but there are instances wherein the lobular inflammation can present as the primary pattern of injury. So what do we mean by lobular inflammation? So when we say lobular inflammation, we see inflammatory cells in the lobules, both in the periportal area, in the centrilobular area, or in the zone 2, in between these two areas. So there are mostly lymphocytic in nature, and in liver, neutrophils doesn't equate for acute inflammation, or lymphocytes doesn't equate for chronic inflammation. So it's different in liver. The two major diseases that will show you lobular inflammation predominantly are acute viral hepatitis and drug-induced liver injury. So in acute viral hepatitis, again, this is often not biopsied, but the clinical presentation and serology is usually sufficient. But if ever encountered, acute viral hepatitis will show aggregates of mononuclear cells that infiltrates either in the sinusoids or within the lobular parenchyma. So the lobules are infiltrated by these inflammatory cells and usually has a minimal inflammation the of the portal tract. Other situations when lobular inflammation becomes the predominant pattern of injury is drug toxicity. So this is a picture from a patient who overdosed with acetaminophen. So the affected area is the lobules. This is the lobules supposedly, but there are no longer viable hepatocytes in the area because of the drug that has been taken. So the most viable area will be the area that is nearest to the portal tract, so as pointed in the arrow, because in this area, aside from its proximity to the blood supply, which is the portal vein and the hepatic arteriole, this is the area where the stem cells or the progenitor cells of the liver is found. So basically, the differential diagnosis for predominant lobular injury are the following. So viral hepatitis, drug-induced liver injury, and autoimmune hepatitis. But in autoimmune, you have also severe portal inflammation occurring with extensive lobular changes. So for the next poll question, which of the following is a key histologic finding in primary biliary cholangitis? Okay. The correct answer is granulomatous florid duct lesion. So periductal fibrosis is a histologic finding that is found in primary sclerosing cholangitis. So we will be discussing the features of primary cholangitis in the next few slides. So the third pattern of injury, the focus is in the bile ducts. So compared to the portal-based inflammation, which is limited to the connective tissue with focal involvement of the bile ducts. So here in this pattern, the main involved structure is the bile ducts. So again, the bile ducts are usually infiltrated by lymphocytes. So when infiltrated by lymphocytes, the normal rosary beads pattern or string of pearls pattern of the bile duct is lost, and they will react with bile ductular reaction or cholestasis. This is because when a bile duct is injured or obstructed, other channels or the bile ductules will be produced to compensate for the blocked bile duct. So again, if there is a blockage in a terminal bile duct, bile flow will be altered, and then bile will accumulate usually in the centrilobular area and will present as cholestasis. So if the pattern of, if the disease becomes progressive, there will come a time that due to the severe injury, your bile duct will be lost. And usually this corresponds to the latter or late stage of the disease. So again, just to show you what a normal bile duct looks like, again, this is almost the same size of hepatic arteriole. So a bile duct should have evenly spaced nuclei, small lumen, non-overlapping, round nuclei, and no cytoplasmic vacuolization. So compared to the bile duct in primary biliary cholangitis. So pointed in the arrow is a bile duct. So it's barely recognizable because of the damage done by the inflammatory cells. So the inflammatory cells in PBC, this is previously named as The name for this is previously termed as primary biliary cirrhosis. So in this disease, the bile duct is infiltrated by lymphocytes or histiocytes. The basement membrane is damaged. So it will show regenerative or reactive changes. So again, the normal, evenly spaced nuclei is lost. Ganito na siya. And it will show cytoplasmic vacuolization, overlapping of the nuclei. So when you block this because of the excessive injury, the periphery of the portal tract will start to produce bile ductules as a reactive phenomenon for the loss or for the injury that is seen in the bile duct. So we call that bile ductular reaction. So in this picture, encircled in red is a bile duct. So again, these are the lymphocytes that infiltrates the bile ducts, surrounded by histiocytes. These are histiocytes and few plasma cells. So the basic inflammatory infiltrates in PBC are lymphocytes and histiocytes. This is what we call a florid duct lesion, or a granulomatous destruction of the bile ducts. So again, in the periphery, what you will see are ductular reactions. So these are small ductules that are created as a reactive phenomenon because of the injury that is happening with the bile ducts. So in time, due to the progression of the disease, the bile ducts will be lost. And here, we can only see a portal vein and a hepatic arteriole with inflammatory infiltrates. So this is important, especially in a patient that has undergone liver transplant, because we assess for chronic ductopenic reaction, wherein we count for the number of portal tracts that has no bile ducts. So if a patient has concomitant PBC, then there will be difficulty in assessing the patient. So there are specimens, or there are cases wherein the florid duct lesions are very prominent. And it even shows giant cell. This is a giant cell surrounded by epithelioid histiocytes. So, but basically, we call this florid duct lesion or a granulomatous reaction. So in PBC, the granuloma is portal-based, while in infection, usually it will be seen in the lobules as well. So whenever we see this florid duct lesion, infection needs to be completely ruled out. So especially in our country, Mycobacterium tuberculosis needs to be ruled out first before considering primary biliary cholangitis. For the key histologic features of PBC, what we see are lymphohistiocytic predominant portal inflammation, but the difference is the bile ducts is involved. In portal inflammation, in viral hepatitis, it may be involved, but only to a mild extent, as opposed to PBC, the main pathology is found in the bile ducts. So as a result, due to the damage in the bile ducts, another feature that we see are the presence of granuloma, or what we call florid duct lesions that are portal-based. And because of the injury in the bile ducts, a reactive phenomenon occurs, which is a bile ductular reaction. And then eventually it will progress to fibrosis and to cirrhosis. So again, lobular inflammation is typically mild to absent. These histologic features are also seen in autoimmune cholangiopathy, or this is what we call the AMA-negative PBC. So basically, they are just the same. The difference just relies on the presence of anti-mitochondrial antibody. So this is in 5 to 10% of the cases. Overall, when PBC is suspected, the diagnosis relies on the combination of clinical presentation, on the presence of high titers of anti-mitochondrial antibody, usually greater than 1:40, with elevation of the GGT, or gamma-glutamyl transferase, and alkaline phosphatase. Viral serology is usually negative, but it can be positive when a concomitant viral hepatitis is present. And the limitation of the biopsy is the heterogeneous nature of the disease. So PBC does not affect the liver uniformly. So meaning that a biopsy may sample a healthy region of the liver while the disease rages on other parts of the liver. So for the differential diagnosis, it depends on whether the florid duct lesion or the granuloma is present or not. Whenever granuloma is present, infection needs to be completely ruled out, or whenever AMA is negative, we can still consider a PBC, but AMA negative PBC, and drug-induced liver needs to be completely ruled out always. Another disease entity that we need to consider is an overlap with autoimmune hepatitis. So true overlap is less than 10% of PBC patients. So pathologically or histologically, we may see we need to see both the features of AIH and PBC. So AIH should have extensive lobular and portal inflammation with plasma cell overrepresentation. For PBC, we need to see florid bile duct lesion and injury to the bile ducts. For serology, we need to see both elevation in IgG and AMA, or anti-smooth muscle antibodies, and anti-nuclear antibodies. For the second disease entity that will show biliary damage or biliary changes, and usually differentiated with PBC, is PSC. So in the poll question a while ago, PSC will show periductal fibrosis. So this one compared to PBC, which has extensive inflammation in the portal tracts that infiltrates the bile duct. Here, what we see is an onion skin type of fibrosis that shows edema. So basically, the fibrosis surrounds the bile duct until it will come to a point that the bile duct will be atrophied. So if you compare it to the size of the hepatic arteriole adjacent to it, a bile duct that has PSC or that has surrounded by fibrosis will be smaller compared to the usual type of the bile duct. So the problem here is that PSC is usually limited to or mostly seen in large ducts. So the use of liver biopsy in patients with PSC is limited. So if large duct PSC, the role of liver will be, again, to stage this disease and to grade the inflammation. Except for patients that wherein small duct primary sclerosing cholangitis is considered. So again, for PSC, the predominant feature is periductal fibrosis, described as onion skin fibrosis, with edema, that's why the color is lighter, and very minimal portal inflammation. So this is one of the cases I've encountered wherein the large duct is completely replaced by the fibrosis. So we call this fibro-obliterative lesion, where the location of the previous bile duct is usually surrounded by fibrous area until it will come to a point that the bile duct is completely obliterated. So most of the time, the small ducts are not affected, but the liver will show downstream obstructive changes. So one of the changes that we see in the liver parenchyma because of an obstruction of a large duct is the accumulation of bile either within the canaliculi or intrahepatic. So this is secondary to the obstruction that is seen, that happened in a large duct, secondary to the sclerosis or the fibrosis that we saw. So for the differential diagnosis, these are the following diseases that are need to be considered and ruled out whenever PSC is considered. For the next question, for the next poll question, which of the following is considered as the histologic defining feature of steatohepatitis? Okay. So our audience is very knowledgeable in NASH, or in Steatotic Pattern. So moving on to the next topic is the steatotic pattern or the fatty change pattern. So basically, the acceptable fat content of the liver is 5%. So this is the portal tract, the central vein, and usually in steatosis, the deposition of fat is observed in the centrilobular area, except in pediatric patients where fat deposition is usually seen in the periportal area. So currently, or the current or future most common cause of chronic liver disease is NAFLD, or the non-alcoholic fatty liver disease. So fatty liver, this is a fatty liver that is not due to alcohol. So basically, NAFLD encompasses a broad spectrum of disease ranging from simple steatosis to the presence of steatohepatitis. So there are two disease entities that is usually discussed in pathology. It's NAFL versus the NASH. So non-alcoholic fatty liver disease, this is a simple or bland steatosis that is usually not progressive. So basically, there is no ballooned hepatocytes, but inflammation in the lobules can be present or not. In NASH, on the other hand, where liver injury is seen, and usually progression to fibrosis and cirrhosis is also associated. So aside from steatosis that we usually see, ballooned hepatocytes with or without inflammation is seen. So NASH is not defined by inflammation, but instead by the presence of ballooned hepatocytes. So this is a picture of a macrovesicular stetosis. That shows you the predominant location will be in the centrilobular area in NASH or in ASH. So there are two types of steatosis. We have the macrovesicular and the microvesicular. The macrovesicular is usually presented as a large vacuole within the cytoplasm that pushes the nuclei to the periphery, as opposed to microvesicular steatosis, where small droplets of fat is seen in the cytoplasm but doesn't push the nuclei to the periphery. So the nuclei in microvesicular steatosis stays at the center. So this type of steatosis is usually seen in toxic injury or fatty liver of pregnancy, so, or in tetracycline injury. So just to illustrate that macrovesicular steatosis can have several sizes. So you have small droplets, these are still macrovesicular steatosis, and large droplet of macrovesicular steatosis. I'm emphasizing this because sometimes there are instances wherein this size of steatosis is mistaken for microvesicular steatosis. So in the presence of ballooned hepatocytes, the diagnosis diagnosis of NASH is justified. So basically, ballooned hepatocytes are enlarged liver that has some form of clearing and aggregates of intermediate filaments. So these eosinophilic aggregates are what we call the Mallory-Denk bodies. They are cytokeratin positive, and these are usually predominant in the presence of liver injury in steatosis. So whenever we see this with steatosis and lobular inflammation, then it justifies the diagnosis of steatohepatitis. So again, just to show you that in NASH and in ASH, the steatosis starts in the centrilobular area pointed by the arrow and eventually will expand to zone 2 and zone 3. So this is a picture in the left lower picture of a trichrome stain performed in a NASH patient. So trichrome stain in steatohepatitis, unlike in viral hepatitis or in autoimmune hepatitis, will show central vein predominant fibrosis. So initially, the fibrosis will start within the central vein. It will expand to the perisinusoidal area or pericellular fibrosis in the hepatocytes that surrounds the central vein. So that's what we call chicken wire fibrosis. So it's a characteristic of NASH and ASH, but it can also be seen in other disease entities such as congestive hepatopathy. So basically, in comparison with portal inflammation in In chronic viral hepatitis, the fibrosis starts in the portal tract. In NASH, the fibrosis starts in the central vein. Most of the time, NASH and ASH cannot be differentiated based on histology. But there are features that will suggest that you are dealing with alcoholic steatohepatitis. So whenever you see increased amount of megamitochondria, increased amount of Mallory hyaline, and aggregates of neutrophils that surrounds the Mallory-denk bodies, this will prompt you to think of alcoholic ingestion or toxicity. So there are very rare instances wherein neutrophils are found within the hepatocytes. Aside from hepatic abscess, we usually observe this in alcoholic steatohepatitis and also in surgical hepatitis. So basically, we have just to reiterate, we have two disease entities under NAFLD. First is the steatosis or the NAFL, which will show you a macrovesicular stetosis pattern with or without lobular inflammation. And the second disease entity is the steatohepatitis, which is associated with a more progressive disease. And in addition to the steatosis and inflammation seen in NAFL or in simple steatosis, we see ballooning degeneration. So basically, large hepatocytes that show Mallory-denk bodies. So these are the differential diagnoses for steatotic pattern of injury. Basically, all of this will show a predominant pattern of steatosis. And also in Wilson's disease, even if it has several morphologic patterns, most of the time it will present with steatosis. So Wilson's disease, it's a rare genetic disorder characterized by abnormal copper transportation. So in the context of pathology, it is typically seen in liver biopsy with steatotic predominant pattern of injury. So however, these features are non-specific. So steatosis is usually seen in the periportal area compared to NASH and in ASH, where the steatosis or the deposition of fat usually starts within the central vein. The liver biopsies in Wilson's will show glycogenated nuclei within the periphery of the portal tract, and also it will show patterns or features of steatohepatitis. So this is a balloon cell or a hepatocyte with ballooning degeneration where aggregates of intermediate filaments are seen. So these are Mallory-denk bodies. So these are the key histologic features of Wilson's disease. So the steatosis is the most common finding, located in the periportal area. Portal inflammation may be seen. That's why this one is also included in the differential of portal inflammation a while ago, but mostly lymphocytic. And in addition to these two, we see nuclear glycogenation, prominent lipofuscin, and Mallory hyaline. So cirrhotic liver may demonstrate variability in nuclear size. So we have a special stain that is used in pathology, that's rhodonine or orcine stain, to demonstrate copper deposition, but only 15% of Wilson's disease will have positive staining for this stain. The gold standard is hepatic tissue copper quantitation. However, it is not available locally. For other disease entities, for alpha-1 antitrypsin deficiency, usually you will see eosinophilic pink globules. So this is a portal tract. We know that this is a portal tract because you have a bile duct, an arteriole, but this portal vein is not seen. So here we see eosinophilic round globules. These are located within the portal tracts. And we used a special stain to demonstrate these eosinophilic globules. So whenever we, these eosinophilic globules may be absent in pediatric patients or in patients that is in later stage or in cirrhotic stage. So this stain is not routinely used in liver pathology, but If clinically suspected for alpha-1 antitrypsin deficiency, this can be requested to highlight the eosinophilic globules that contains alpha-1 antitrypsin that is located in the periportal area. For hemochromatosis, this is a picture showing pigments in the hepatocytes and also in the portal tract. So basically, compare this to pigments, to lipofuscin pigments that are more predominant in the central vein. So these one are more coarse in nature, and whenever in early stage of the disease, it will only be limited in the periportal area, but later on, it will progress and it will diffusely involve the entire liver parenchyma. So these arrows are pointing to the bile ducts and vessels that also contains hemosiderin pigments. So whenever these hemosiderin pigments are seen in the bile ducts and even in the endothelial cells, it's a sign that the disease is already severe because it even involves the bile ductules already and the endothelial cells. So to make sure that these yellow-brown pigments are really iron, we do Prussian blue stain or Pearl's iron test. So the iron or the granules that we saw in H&E will be stained and will be color blue whenever we use a Pearl's iron test or a Prussian blue stain. So basically, for all these patterns of injury, if progressive, it will show you fibrosis eventually. So from portal tract, the minimal deposition of collagen, it will expand the periportal until it will come to a point that it will form fibrous septae to join an adjacent portal tract. So whenever we see a portal-to-portal connection of fibrosis, we call it bridging fibrosis. And then eventually, if progressive and if not controlled, the bridging fibrosis will progress to cirrhosis, and we need at least 2 cirrhotic nodules to confirm that the diagnosis is cirrhosis. So basically, these nodules are regenerative nodules that will eventually may progress to small cell change or large cell change that is seen in these plastic nodules. So there are 2 types of cirrhosis. We have the biliary type of cirrhosis that basically shows jigsaw puzzle. So here, the nodules are not completely enclosed by fibrous tissue, but these are irregular regenerating nodules. Usually this is the result of, this is a type of cirrhosis found in PBCs and in PSCs. Compared to the non-biliary type of cirrhosis, so in this first picture, this is a liver core that shows you nodule formation. Here, this is a nodule and fibrous septa. So this is bridging fibrosis. So as we can see in H&E, the nodules or deposition of fibrosis is not evidently seen compared to the trichrome stain, wherein the nodules are well defined because the fibrosis is stained as color blue and highlighted by the trichrome stain. So for the grading and staging, we have several grading schemes that is being used in medical liver. So basically, we have 4 grading schemes in chronic hepatitis, we have 2 in NASH, and we have 2 in chronic biliary disease. So there is no single recommended grading scheme for staging and grading the chronic liver diseases, but it will depend on the institution you are working at. So if your the important is that your clinician understands the grading scheme that you are using or that what pathologists are using. So in the institution where I'm working at, what we used is an Ishak score and a Metavir score. The Ishak score is the modified Nodel, that's the previous Nodel scoring, or the histologic activity index. So basically for liver biopsy of non-neoplastic, what is expected to be seen in biopsy report is the predominant pattern of injury, the grade of the disease, meaning the extent of inflammation, and the stage or the extent of fibrosis. So fibrosis is usually assessed in trichrome stain. The grade is assessed in hematoxylin and eosin stain. So apart from this, aside from this, a list of differential diagnosis in order of priority is also given because of the extensive overlap in the pattern of injury found in the liver. So that's all for the non-neoplastic liver.
Okay, before we move on to the neoplastic lesion of the liver, actually two of our attendees raised their hands. So may I acknowledge Dr. Vic Ang for his question. Dr. Ang?
Yeah.
Yes, Dr. Ang.
Yeah. I was asking about piecemeal necrosis. Do you find piecemeal necrosis on the lobular area or periportal area mostly?
Thank you for your question, Doc. So, Doc, basically interface hepatitis or piecemeal necrosis are synonymous. So, interface hepatitis is found in the periportal area. It's in the first layer of hepatocytes that abuts the portal tract. So, it's the limiting plate that is involved. So, basically, eventually, because of inflammation, the hepatocytes within the portal tract will undergo necrosis. That's why it's also called piecemeal necrosis.
Okay, thank you.
Okay, so let me acknowledge another one from one of our attendees also for his question, Dr. Leo Lagade. Sir, Dr. Lagade. So parang nawala na siya ata. Dr. Lagade? Okay. So anyway, mukhang nawala siya. So, Doctora, some question I'll ask, I think the others were answered during our lecture. So, someone, an anonymous attendee, question, what disease entities can you see acute and chronic triaditis? But probably before you answer the question, Doctora Mafe, can you tell us what triaditis is? Is it similar to portal inflammation or lower inflammation?
So maybe from the word itself, triaditis, it will involve inflammation both of the portal vein, the hepatic arteriole, and the bile ducts.
So, I mean, to answer the question, all of the condition that were mentioned by Doctor is similar na yung acute and chronic. Okay, Doctora, this is a personal question. One of the things that is really hard to differentiate, correct me if I'm wrong, is autoimmune hepatitis as some of the drug-induced liver injury pattern. No, unless, of course, you have already your autoimmune markers. No, so are there any features that you can actually use to differentiate whether you're dealing with someone with autoimmune versus someone with drug-induced liver injury?
Actually, the drug-induced liver injury is always in the differential of all the patterns. So there are drugs that will really show you like autoimmune hepatitis-like pattern. But what we usually use for, aside from the serology, should be the overrepresentation of the plasma cells and the presence of the features that I've mentioned. But there are drug-induced liver injury, like for example, the immune checkpoint inhibitors that will really show exactly the same histologic feature. So the only way is to do serologic testing.
Thank you, Doctora. Any more question before Doctora will move on to the next topic? Okay, if there's none, again, Doctora, you may move on to the next topic.
Moving on to the neoplastic liver. So I've divided my topic into two. So the primary tumors versus metastatic tumors. So basically, we all know that metastatic tumors are more common than the primary ones, but my the way I've divided it is based on the cell of origin. So hepatocytic in nature, cholangiocytic in nature, or vascular in nature. So the most common primary tumor of the liver is hepatocellular carcinoma. So this is usually found in the background of cirrhosis. So just to help you remember that the normal hepatic parenchyma should appear like this. It is single layer, one cell thick plate of hepatic cords lined by sinusoidal endothelium. The cells should be almost round nucleus. The chromatin is vesicular, hindi siya dapat dark. Now, if we compare this to a hepatocellular carcinoma, we can see it's very evident that the single layer of hepatocytes is altered. So here, instead of one, we have more than one. So meron tayong 1, 2, 3, 4. 5-cell thick plate of hepatic cords. Aside from that, the fenestrated endothelium here in normal liver parenchyma is lost. So in hepatocellular carcinoma, from sinusoidal type, fenestrated type, the endothelium will become capillary type. So these neoplastic cells will be wrapped by endothelial cells that if you stain it, it will be positive for CD34. So aside from this, the normal structures are lost. So the portal tracts are not seen in normal distribution, as I've mentioned. The trabeculae are thickened, and sometimes we see bile. So in liver biopsies, whenever we see bile or eosinophilic globules, and we see the architecture of similar to like this, we usually outrightly diagnose it as hepatocellular carcinoma. And immunohistochemical stains are not used anymore if bile is seen, if the architecture and the cytology reflects or has a resemblance with hepatocytes. The problem arises when the lesion is well differentiated, because it will be hard to differentiate it with a benign lesion such as hepatocellular adenoma, or when the tumor is poorly differentiated. So clues are, again, the presence of bile, or whenever you see fatty change or glycogen content on the cytoplasm, and at the same time, eosinophilic globules. But these are just soft clues. So hepatocellular carcinoma can have several morphologic appearance. There are instances wherein in biopsies, we just see tumors like this that usually have, what we see here are small cells, small round cells that has high NC ratio. So whenever we see this is a small cell change in hepatocellular carcinoma. It's very difficult to differentiate it with a neuroendocrine neoplasm. That's why for a morphologic variant of HCC showing small cell change, we usually request for neuroendocrine markers, because it will look similarly because of the nested appearance, and also may seemingly appear to have salt and pepper chromatin. Also, there are instances wherein the hepatocellular carcinoma will have these pseudoglandular structures. So these pseudoglandular structures can appear glandular in nature. So whenever we are confused with this appearance or with these structures, the differential diagnosis of cholangiocarcinoma is also entertained. So we use adenocarcinoma markers and hepatocytic markers to be able to resolve this dilemma. So these are the features that we look for to outrightly say that the tumor is hepatocellular carcinoma. It should have resemblance with hepatocytes with atypia. If there's no resemblance with hepatocytes, immunohistochemical stains is recommended for you to prove that it's really hepatocytic in nature. Again, the portal tracts, the architecture is altered. You don't see portal tracts. You see unpaired arteries. As we've mentioned, an arteriole should be paired most of the time with bile duct. And one cell layer, one cell thick plate of the hepatocytes is altered also. So whenever we have difficulty for poorly differentiated hepatocellular carcinoma, we do HepAR1, glypican 3, and arginase 1 to prove that it is really hepatocytic in nature. While this is not, well, CK19 and MOC31 usually positive for adenocarcinoma or cholangio, but they are not specific or non-specific adenocarcinoma markers. So meaning that they can also be positive for adenocarcinoma that are from extrahepatic location. So basically, the differential diagnosis for hepatocellular carcinoma are the following. So again, as we've mentioned, in moderately differentiated, showing bile production, eosinophilic globules, and glycogen content, it is usually diagnosed outrightly as hepatocellular carcinoma. The problem will be in the well-differentiated and in the poorly differentiated type. So these are all resolved by reticulin and proper evaluation of other areas of the tumor. And in poorly differentiated, these are the following stains that we request for. I've mentioned already about neuroendocrine neoplasm. Sometimes whenever clear cell change is observed in hepatocellular carcinoma, we confuse it with renal cell. So what we do, we request for PAX8, which is positive for renal cell and negative for hepatocellular carcinoma. And again, for cholangiocarcinoma, if it's really poorly differentiated. There are several histologic variants of hepatocellular carcinoma. So basically, the typical picture is a malignancy or hepatocellular carcinoma in the background of cirrhosis. So this one deserves a special mention because this is a subtype of hepatocellular carcinoma that occurs in young patients or in young adults. Aside from the population that is involved, the appearance also differs because this type of hepatocellular carcinoma will show you increased amount of fibrous stroma. So that's why it's called fibrolamellar, because the fibrous area appears to be parallel to each other. Now, the problem here is that mostly or most of the time, hepatocellular carcinomas doesn't have this amount of fibrous stroma. So the problem here, if whenever you see fibrous stroma, you will entertain cholangiocarcinoma as your differential diagnosis. So again, this will be resolved by immunohistochemical stains, but soft clues for you to tell that you're dealing with fibrolamellar hepatocellular carcinoma is the presence of densely eosinophilic cytoplasms of the tumor cells, and sometimes you see the oval pale bodies that will make you lean more towards fibrolamellar HCC as a diagnosis. So these are the key features of fibrolamellar carcinoma. It occurs in non-cirrhotic liver, affects young adults, and the main histologic picture will be a fibrostroma that has lamellae that are arranged in lamellae that has varying thickness. It can form pseudoglands similar to a hepatocellular carcinoma. That's why it warrants differentiation with a cholangiocarcinoma or an adenocarcinoma. And the cytology, as I've mentioned, will show deeply eosinophilic cytoplasm with pale bodies. So also this type of tumor will show a different staining pattern. So normal hepatocellular carcinoma tumor will be negative in cytokeratin 7 and cytokeratin 20, while fibrolamellar carcinoma will show a positivity in CK7. Also, there's a stain that's being used, but not specific for fibrolamellar carcinoma. That's CD68, but a specific clone should be used, KP1 clone. So that's all for hepatocellular carcinoma. Now, the next hepatocytic tumor is a benign lesion that is composed of multiple spherical aggregates of hyperplastic hepatocytes. So again, the nodules are divided by the fibrous septa. So this is the fibrous septa, and usually it contains large vessels that has eccentric hypertrophy, And brisk ductular reaction is being noted. So in this lesion, it's benign because the hepatocytes are not atypical. The plates are still one cell layer. It can go up to 2. The reticulin framework is still maintained. But what you see are pseudoportal tracts. It doesn't contain the normal distribution of the portal tracts. So again, your differential here would be cirrhotic nodule because of this benign looking hyperplastic nodules and hepatocellular adenoma. So in resection, it will be easier to observe because you see the entire picture. But in biopsies, usually, especially if the fibrosis scar is not sampled, most of the time, the difficulty is distinguishing FNH versus hepatic adenoma. So this is a picture just to show you that FNH has these large arterioles that exhibits hypertrophy of the medial layer. So this is usually observed in the fibrosepta. This is more common in FNH with associated bile ductular reaction. If seen in the biopsy, so like for this sample, what we see are ductular reaction and fibrosepta with a vessel or an arteriole. So usually the one cell thick plate is maintained. There are no portal tracts, but what we see are pseudoportal tracts, and brisk ductular reaction is seen. A stain that we use to differentiate FNH to other type of benign tumor, which is hepatic adenoma, is glutamine synthetase. It's available locally, so an FNH will have a staining pattern as a map-like pattern, meaning anastomosing pattern, as opposed to hepatic adenoma, which will usually stain with expanded perivenular or centrilobular pattern. For hepatocellular adenoma, this is a benign neoplasm that arises in a non-cirrhotic liver. So we have 4 histologic subtype. First is the HNF1 alpha subtype, the hepatocytic nuclear factor 1 alpha. Second is the beta-catenin activation subtype and the interleukin 6 subtype. So the last subtype is the unclassified subtype. However, there are recent studies wherein in the classified subtype group, they were able to find a specific sonic hedgehog hepatocellular adenoma that usually correlates with increased risk of hemorrhage. So SHH upregulates the arginosuccinate synthase 1. So that's a stain that we use to classify this type of adenoma. So, but it is not available locally. So I've included this table to mention that the beta-catenin subtype of hepatocellular adenoma has 40% risk of malignancy and will affect 40% of the male population as compared to the other types of adenoma. So for HNF1 alpha, 90% it will be women. For inflammatory subtype, it will also be most of the time female. But in beta-catenin, 40% of the population will be male. Aside from the risk of malignancy, this is the subtype of adenoma that will show you atypia, but the changes are not sufficient to call it as hepatocellular carcinoma. Again, for the SHH subtype, this is usually associated with increased risk of hemorrhage. So just to show you that hepatocellular adenoma is usually solitary. It is well circumscribed, but it's not capsulated. So it's unencapsulated, but the delineation between the adjacent liver parenchyma is well defined. So basically, this lesion doesn't have normal distribution of portal tracts, but will have one cell thick layer, but may increase up to 2 layer of hepatocytes, but that appear benign looking. So this is a higher power magnification of the picture in the first column, wherein we see that the normal trabeculae is still maintained. The nuclei of the site of the hepatocytes are not atypical, they are not enlarged. The NC ratio is still normal NC ratio is still evident. There is a specific subtype of an adenoma that may be confused with FNH. So FNH, as I've mentioned, will contain inflammatory fibrosepta with arterioles. It will contain ductular reaction. It will also may show dilatation of the sinusoids. So this specific subtype of hepatocellular adenoma can show pseudoportal tracts, maybe because of the inflammatory cells seen, and the sinusoidal dilatation. So this one, when seen in an adenoma, it most likely supports the inflammatory subtype of hepatocytic adenoma. So we call it previously as telangiectatic type of hepatocellular adenoma. The most important subtype for hepatocellular adenoma is the beta-catenin subtype because of its increased risk of malignancy. So again, comparing it to the previous slide, this type of adenoma show a mild atypia. So even if the one-cell thick plate layer is maintained, the nuclei shows prominent nucleoli or a little bit larger nucleoli, and sometimes acinar pattern are seen. Whenever we suspect for hepatocellular adenoma, we do beta-catenin staining and glutamine synthetase staining, but it's not available in this institution where I am affiliated. So basically, we don't do subtyping of the adenoma here in the country because of the unavailability of the stains that are recommended. So what is available in the country is beta-catenin and glutamine synthetase, but it's usually not requested anymore. For the cholangiocytic type of primary tumor, the most important one is the cholangiocarcinoma or the intrahepatic adenocarcinoma. So basically, this malignancy will show the same features with pancreatic adenocarcinoma and extrahepatic cholangiocarcinoma. They will all look the same, wherein the stroma is abundant and the glands are low-cuboidal and distributed in a haphazard pattern. So whether extrahepatic, pancreatic, they will all look the same. And the problem is there is no immunohistochemical stain specific to differentiate intrahepatic cholangiocarcinoma versus extrahepatic cholangiocarcinoma and pancreatic adenocarcinoma. But there are some stains that will just suggest, because of its positivity or loss of expression, will suggest that it may be cholangiocarcinoma, but not 100% specific for it. So for cholangiocarcinoma, the architecture should be low-cuboidal, haphazard arrangement, and the important description is increased desmoplastic stroma. Whenever confusion is present, we do stains that will differentiate it from extrahepatic adenocarcinoma. So in some studies, BAP1 is used to differentiate intrahepatic cholangiocarcinoma versus extrahepatic cholangiocarcinoma. But this stain is only useful when it is lost. Retained expression will not tell you that it is cholangiocarcinoma. It is not cholangiocarcinoma. So these are the following stains that we used for adenocarcinoma marker. And the differential diagnosis include both benign lesions and malignant. So there are instances wherein the bile ducts are proliferating in the liver parenchyma. These are bile duct hamartoma and bile duct adenoma. So the difference is in the pattern of infiltration and in the presence of atypia. While the differential for malignant neoplasms in cholangiocarcinoma are the following. So whenever glands are seen in the liver, the diagnostic algorithm is to always rule out a metastatic process or a metastatic adenocarcinoma or an extrahepatic adenocarcinoma that arises from organs outside the liver, whether it is in the pancreas, in the colon, or elsewhere. So we use several stains to do this. Basically, for cholangiocarcinoma, we use the staining pattern of CK7 and 20. However, this is often variable because cholangiocarcinoma can have CK7 positivity, 20 neg, or both positivity. On immunostains that is available in the institution where I'm affiliated are SMAD4 and BAP1, which I found really helpful to support cholangiocarcinoma malignancy if really suspected. So for extrahepatic adenocarcinoma or extrahepatic cholangio, the following stains are used to identify the primary lesion. So for colon, we have enteric markers, CDX2 and SATB2. So these are marker because usually we need two markers to have to adequately say that the tumor is coming from this certain site. For prostate, we use NKX 3.1 and PSA. For renal, we use PAX8 and sometimes renal cell antigen, RCC antigen. For lung, we use TTF1 and napsin A. And for thyroid, we use PAX8 and thyroglobulin. So this is an actual case that I've encountered. So this is a 60-year-old female which has descending colon mass and at the same time liver masses located in the segment 2 and segment 3. So the patient underwent left hemicolectomy and lateral segmentectomy. So the appearance of the descending colon mass is like this. What we see are complex glands that infiltrates the stroma. The stroma is not that abundant. And the characteristic appearance of the neoplastic glands are more columnar in nature. And if you look at the nuclei, mas elongated siya, more elongated in appearance. Now, compared it to the biopsy that is found in the liver, wherein the tumor showed, compared to the colon, it's more low cuboidal in nature. The elongated or pseudostratified nuclei is not observed, but here what we see are round to ovoid nuclei. So also, aside from this, we see abundant stroma. So basically, what we need to do is, we need to identify, apart from the difference in morphology, we need to support this by immunohistochemical stains to make sure that the tumor in the liver is not metastatic. So what we did, our panel of immunohistochemical stains, CK7 and CK20, which showed opposite results. For the colonic mass, the staining pattern showed positive CK20, while for the liver mass, it showed CK7 positivity. So we requested for enteric markers to say that this one is really from colon and to say if this one came from the colon or came from the liver itself. So the ones in the colon stained for SATB2 and CDX2, while the liver masses stained negative for SATB2 and CDX2. And in addition to that, there is loss of expression of SMAD4 in the liver mass and retained expression in the colon. So this is a case of two primary lesions, two primary malignancies that is present both in the colon and in the liver. So the patient has adenocarcinoma of the colon and an intrahepatic cholangiocarcinoma in the liver. So the last primary tumor is the vascular neoplasan. So basically, there are two important neoplasms that I would like to mention. First one is hemangioma. This is a benign vascular neoplasm that will show you several vascular channels. So these spaces mimics vascular channels, and these are lined by endothelial cells. So the endothelial cells are flat in nature. So basically, this is hypocellular. More of fibrous tissue kasi nakikita pa natin are yung mga pink areas. Now, compare this to angiosarcoma. So, compared to hemangioma, angiosarcoma is very cellular. You see vascular channels, these are the spaces, mimics the vascular channels. But compared to hemangioma, these are smaller and these have more nuclei compared to hemangioma. And the nuclei are more pleomorphic. And aside from that, you see several mitosis. So this warrants a diagnosis of, aside from the infiltrative character of the tumor, the presence of atypia, mitotic activity will warrant a diagnosis of angiosarcoma. So just to put it in a table, just to enumerate the immunohistochemical stains that we use to support vascular tumor, we use ERG stain, which is a nuclear marker, a CD31 and CD34 stain. So that's all for the neoplastic liver.
Yes. In the interest of time, we'll allow Dr. Bonifacio to continue with her lecture and defer the Q&A until she finishes her topic on the pancreas. Okay, Dr. Bonifacio.
Okay, for the last topic, which is the pancreas. So for the pancreas, the normal histology is predominantly composed of lobules of acinar cells. So these acinar cells have eosinophilic granules, so located above the nucleus. These granules usually contains the enzymes, the trypsin, chymotrypsin, and peptidases. So these acinar cells are connected by the intralobular ductal cells. These are ductal cells described as locuboidal. So connected to the main pancreatic duct until it will drain to the duodenum. And 1 to 2% will be the endocrine function, will be composed of the endocrine function of the pancreas, and it is seen in the islets of Langerhans. So I'm telling the normal architecture because to tell you the importance in FNA or in biopsies. So usually to say that a normal biopsy is normal, we should see a predominant acinar cells and few ductal cells. Whenever ductal proliferation are seen in biopsies and the morphology is altered or show a typical appearance, then we highly suspect a malignancy that is ductal in origin. So for the next poll question, mostly got the correct answer. So there are 3 important mucinous lesions in the pancreas that we usually encounter. So, and these are the mucinous cystic neoplasm, intraductal papillary neoplasm. Both are grossly visible. And the third mucinous lesion is the pancreatic intraepithelial neoplasm, or what we call the panning. This is usually microscopic lesion, not found in imaging and not found in gross inspection or dissection. So this is a picture of mucinous cystic neoplasm, wherein we see mucinous epithelial lining with ovarian type of stroma. So the main differentiation of MCN, or mucinous cystic neoplasm, with IPMN, or intraductal papillary mucinous neoplasm, is the presence of ovarian stroma. This ovarian stroma is stained using the estrogen receptor or the progesterone receptor. Now, we compare it to intraductal papillary neoplasm, wherein pointed in the arrow is the subepithelial layer that is acellular. So basically, wala kang ovarian stroma in IPMN. And whenever you see lesions like this in the bile duct, we call it IPNB, intraductal papillary neoplasm of bile duct. Whenever we see it in the gallbladder, we call it intracholecystic papillary neoplasm, or ICPN. And if we see it in the ampulla, we call it intraampullary papillary tubular neoplasm. So IPNN can be mast forming but located within the ducts. So it has basically 4 histologic subtypes. We have the gastric phenotype. So I'm emphasizing this because sometimes the biopsies can be mistaken for gastric epithelium. We have the intestinal type. This is important because most of the time, the associated invasive malignancy is colloid type carcinoma, which has a better prognosis. The third type of IPMN is the pancreatobiliary type, which has low cuboidal appearance compared to the intestinal type. So pancreatobiliary type is rare, but there is a higher chance of recurrence whenever this one is present. The fourth histologic subtype that is formerly classified under IPMN is the Oncocitic subtype. Now, in the new WHO classification, this subtype is categorized separately because it has been found out that Jamias mutation is not present in this type of tumors, unlike with other three types of histologic subtypes of IPMN. So this is a table showing you the difference between MCN and IPMN. So the main differentiation is the ductal communication and the ovarian type of stroma. So IPMN will be connected to the pancreatic duct, either the main pancreatic duct or the branch pancreatic duct, and MCN will have the ovarian type of stroma. For the flat precursor lesions, basically they are not flat, but they are microscopic in nature. So we don't see them grossly. Before, it used to be graded as Panin 1, Panin 2, and Panin 3. But now we use the two-tiered classification, the low grade Panin and the high grade Panin. Low grade will cover for Panin 1 and Panin 2. High grade will cover for Panin 3. So the difference is, in Panin 3, it's more complex and the nuclear polarity is lost. So your nuclei will reach up to the top of the cell. How do we differentiate it? Basically just based on the size, because IPMN is grossly visible and Panin is microscopic in size. But both can have mucin production, they can be papillary in nature, but both of them occur in intraductal. So the limitation for mucinous cyst in small biopsies is the lack of stroma. So this is a biopsy that came from a cystic lesion of the pancreas. So the first thing we usually do is to categorize whether it is mucinous or not. And further subclassification of mucinous cyst is difficult because sometimes stroma is not present. As we've mentioned, the presence of stroma usually will tell you that the tumor is MCN if ovarian stroma is present, or if not present, it's categorized as IPMN. So for this one, we can only tell that this is mucinous cystic neoplasm, but since we don't see the stroma, we can't tell whether it's MCN or IPMN, and imaging needs to be correlated with this one. The next thing we assessed for is the presence of dysplasia, whether it's low grade or high grade. High grade will show you loss of nuclear polarity. So overall, with that limitation, a mucinous cyst can be further characterized in combination with radiologic findings. So MCN has no communication with pancreatic duct. IPMN communicates with pancreatic duct. When you examine the fluid, both will show elevated CEA. The cutoff is usually 192 nanograms per ml. If you do molecular testing, MCN will be negative for GNAS mutation. IPMN will show GNAS mutation in 60% of the tumor. And then histologic findings, MCN will show you ovarian type of stroma. IPMN will show you a cellular or hypocellular stroma. For the non-mucinous cyst, a rare benign cyst that is usually associated with von Hippel-Lindau mutation is Cirrhosis Adenoma. So the presentation is collection of microcysts lined by low cuboidal, this is low cuboidal, separated by fibrous tissue. So the stroma is fibrotic. The lining epithelium is bland, as you can see here. Low cuboidal, no mitosis, almost the same in nuclear size. So the problem here, whenever it shows mild atypia and clearing or glycogenation, sometimes we need to differentiate it with a metastatic clear cell renal cell carcinoma, and apicoma, or a perivascular epithelioid cell neoplasm. So immunohistochemical stains is very helpful for differentiating this type of lesion. The next non-mucinous cyst is a pancreatic pseudocyst. Basically, it's not a real cyst because it has no lining. So they form in the pancreas next to a pancreatitis. And here we don't see epithelial lining, it's denuded. And it is formed when a damaged pancreatic duct will release its secretions to adjacent interstitium, and then it will be walled off by this fibrous tissue. The fluid biochemistry compared to mucinous, diba, ang mucinous will show elevated CEA. Non-mucinous, especially pancreatic pseudocyst, will show you low CEA and high amylase because of the association with pancreatitis. These are the differential diagnoses for non-mucinous cyst. In pathology, one of the ways we categorize pancreatic tumors is whether the tumor stroma is abundant or scant. So in cases where the tumor stroma is abundant, it is usually firm or scirrhous, grossly. When the tumor stroma is poor, it is more fleshy in appearance. So this is how we subcategorize the solid lesions in the pancreas. For stroma-rich, our differentials will include ductal adenocarcinoma and chronic pancreatitis. For stroma-poor lesions, the differential will include round cell tumors, neuroendocrine, acinar, pancreaticoblastoma, and solid pseudopapillary neoplasm. So first is a ductal adenocarcinoma. Microscopically, ductal adenocarcinoma are gland-forming, low cuboidal. You compare it to colon, which is tall columnar in nature with pseudostratified hyperchromatic nuclei. So these glands will be infiltrated by this abundant fibrous stroma. So this is the stroma. Whenever we see this, it will tell you that you are dealing with a pancreatico-biliary type of tumor, because this will be similar to tumors also in intrahepatic or extrahepatic cholangiocarcinoma. They will have the same morphology. So these tumors will be proportional to the degree of differentiation. So the gland formation, will be proportional to the differentiation. If you see a lot of glands, the grading will be well differentiated. When you see single or sheets of atypical cells, then the grading will be poorly differentiated. Adenocarcinoma of the pancreas is notorious for its often benign deceptive appearance. So if you are going to look at this, it most likely will look like the bile duct that I've shown you a while ago, where the nuclei are a little bit more uniform in nature. It's small, but what is peculiar is the presence of mitosis. And if you look at the big picture, this gland will be infiltrating in an abnormal location. If you compare it to a benign gland, where the nuclear size are more uniform and you don't see mitosis within the epithelium. So if we look at the big picture of this one, the lobular architecture is maintained. So the problem will be in smaller biopsies. So as I've mentioned, lobular architecture is maintained in chronic pancreatitis. If adenocarcinoma is suspected, then the glands will be here in the area and the lobular architecture is not maintained. The acinar cells are lost because of pancreatitis, and what is left are atrophic, benign-looking glands. Another differential for adenocarcinoma is autoimmune pancreatitis. So this is a radiologic and clinical mimic of pancreatic adenocarcinoma. So it is duct-centric of inflammation. This is the pancreatic duct surrounded by inflammation. Mostly, the inflammatory cells are mononuclear. It will show you pinwheel type or storiform fibrosis. And if you use IgG4 stains, this will pick up the stain, but IgG4 stain is not available locally. So this is a picture of autoimmune pancreatitis. The features will include the following criteria. You need at least 50 IgG4 plasma cells that infiltrates in the periductal area. You have storiform fibrosis or pinwheel fibrosis and obliterative phlebitis. So this is a differential of pancreatic adenocarcinoma because of the presence of abundant stroma that may be mistaken for a malignancy in imaging and even in clinical. So just to differentiate chronic pancreatitis to acute pancreatitis, although we don't receive this in pathology, most of the time, acute pancreatitis is appreciated in autopsy specimens. So basically, the pancreas is digested. It will show foci of hemorrhages. And what you see is are saponifications or calcifications with necrotic fragments. So the normal architecture is not maintained anymore, and the normal acinar cells are not appreciated. For the last poll question, a pancreatic tumor is diffusely positive for chromogranin and synaptophysin with a proliferation index of 50%. Which of the following is an appropriate statement? Okay. The correct answer is the tumor could represent either a grade 3 well-differentiated neuroendocrine tumor or a poorly differentiated neuroendocrine carcinoma. So this is the recent update in neuroendocrine neoplasm. So neuroendocrine neoplasm will usually present with organoid pattern. When we say organoid pattern, it's nested, highlighted by the red marker, and it will show salt and pepper chromatin. So in WHO Neuroendocrine 2017 and 2019, neuroendocrine tumors are categorized or is categorized into one spectrum. They call it neoplasm anymore, not tumor, neuroendocrine neoplasm, that encompasses well-differentiated NET and poorly differentiated NEC. So in previous classification in the gastrointestinal tract and pancreaticobiliary tract, the classification is just 3-tiered, wherein we have a poorly differentiated grade 1, a well-differentiated grade 1, a well-differentiated grade 2, and the poorly differentiated NEC. These are differentiated before based on the mitotic count, where grade 1 has less than 2, the proliferation index has less than 2%, and poorly differentiated NEC will have 20 mitosis and 20% proliferation index. Now, the update is the addition of the new category, which is the grade 3 well-differentiated NET. So this one has the same mitotic count with the poorly differentiated NEC and has same proliferation index with the poorly differentiated NEC. So therefore, a well-differentiated NET that is grade 3 cannot be differentiated with poorly differentiated NEC that is grade 3. So in the new WHO in 2017 and 2019, the previous studies showed that the grade 3 classification of neuroendocrine neoplasm is very heterogeneous, and it can be further subdivided into 2 groups. They subdivided it in a well-differentiated NET, which is a high-grade NET because of the increase in mitotic count and proliferation index, and into a poorly differentiated NEC, which is also a high-grade neuroendocrine neoplasm, but will show a morphology of large cell or small cell carcinoma. So the difference is that they have found out that grade 3 well-diff NET has stable disease progression. It has regular response to therapy, and it has diffuse avidity to octreotide scan. As opposed to the second group, they have found out that it rapidly progresses, it is refractory to therapy, and it has negative or weak activity on octreotide scan. So how do we differentiate it histologically? So a well-differentiated net will show a previous grade 1 or a grade 2 pattern of malignancy. Or if you are dealing with a resection specimen, there are areas that will show typical well-differentiated morphology. If these are not seen, molecular testing may be done, and this group have shown loss of the AXX or ATRX expression. As opposed to poorly differentiated neck, this one is not associated with an area of well-differentiated, but most of the time, it is mixed with a conventional carcinoma. So in this group, it has been found out that RB and P53 has aberrant expression. So RB is lost and P53 has aberrant expression. So distinction can be challenging in small biopsies because you don't see other areas that will show well-differentiated morphology, but a trial of immunohistochemistry is often done and may resolve the dilemma. The next trauma-poor tumor is the acinar cell carcinoma, which is a very cellular tumor that has morphologic resemblance with acinar cells of the pancreas. So also there is evidence of pancreatic exocrine production. So again, this has minimal type of stroma, and what is particular here is the presence of enlarged prominent cherry red nucleoli. So this has no mucin, so we can't categorize it as ductal because there is no mucin, and the cytoplasm is often granular. Compare it to a pseudopapillary neoplasm, which also appears as round, but what is prominent is the presence of vessels in the center of the tumor. So basically, these are just pseudopapillary, the pseudopapillae, and not real papillae because this is a blood vessel surrounded by tumors. It looks like papillary because the tumor cells that are away from the vessels will start to detach because of the decrease in blood supply that they are receiving. So these appears to be the rosettes that is similar to rosettes that are found in ependymoma. So aside from that, the nuclear grooves are seen. It's a characteristic of solid pseudopapillary neoplasm and the presence of eosinophilic hyaline globules. So basically, for stroma-poor category, we have an acinar cytoplasm that is described as round. For the round cell neoplasm that produces exocrine enzymes, it can look like a neuroendocrine neoplasm because it's also round. Sometimes will show acinar pattern also, and can also look like solid pseudopapillary neoplasm because of the round characteristic of the tumor. So basically, in stroma-poor neoplasms, they can all look the same, round cell neoplasm. That's why whenever we encounter these tumors, we often request the following immunohistochemical stains to really tell that these neoplasms are acinar in nature, are pancreatic in nature, or they are solid pseudopapillary. So for acinar, we use trypsin, chymotrypsin, and BCL10. For pancreas, neuroendocrine tumor, we use chroma and synapto. And for SPN, aside from the clinical information, we use beta-catenin, CD10, and progesterone receptors. So that's all for the topic of pancreas. And thank you very much.
Thank you very much, Dr. Bonifacio, for that very extensive discussion on the pathology involving the liver and the pancreas. So in the interest of time, we're running a bit late. Medyo gutom na siguro yung mga tao. We'll be entertaining 3 questions. So the first question is from Dr. Payawal. So what immunohistochemical stains are available in the Philippines to differentiate intrahepatic cholangiocarcinoma versus hepatocellular carcinoma, since management significantly differs between the two?
Okay, thank you for the question, Dr. Bayawal.
Payawal.
So, Bayawal, yeah. What we used is, we need to establish that the tumor is hepatocytic or cholangiocytic in nature. So for hepatocytic, we use Hepar1, Arginase 1, and Glypican 3. So aside from that, we can also use polyclonal CEA and CD34 for hepatocytic. But for cholangiocarcinoma, we use CK19, MOC31, and if we want to establish that it's intrahepatic versus extrahepatic cholangio, we use BAP1, but the interpretation is loss of expression. And also, we can also use SMAD4, but also the interpretation is loss of expression.
Okay, someone raised his hand. So, Dr. Potot, Hans Potot is raising his hand. So, Dr. Potot, what's your question? Dr. Hans?
Oh, Brad's gonna love this. Oh my, you're kidding me.
Dr. Hans? Do you?
Yeah.
Yes.
Sorry, I just accidentally pressed it.
Okay. Thank you. Okay. So, Doctora, in relation to Dr. Payawal's question, I think one of the emerging tumors specifically occurring among non-cirrhotic livers is a mixture of liver hepatocellular and cholangiocarcinoma. So how do you make such a distinction? Because, I mean, as far as I can remember, you manage whichever is the more predominant lesion. So if it's more leaning toward cholangiocarcinoma versus one leaning more hepatocellular carcinoma. So how do you make a diagnosis of a mix like a hepatocholangiocarcinoma, or are there any immunohistochemical stains that are available to distinguish this from the usual hepatocellular carcinoma and cholangiocarcinoma?
Yeah, that's a very good question actually. So I didn't include that in the lecture, but it is an update in the new WHO of the digestive system. We have a category of combined hepatocellular and cholangiocarcinoma neoplasm. So there is no recommended percentage as long as the tumor has a classic hepatocellular carcinoma and a morphology of adenocarcinoma. We call it as combined hepatocellular carcinoma. So if the morphology in H&E is enough, we can call it directly as combined. But if the lesion is poorly differentiated, an overlap of stains will be used. For example, the two populations of tumors will be stained, and one population will stain with hepatocytic markers, the second population will stain with cholangio markers. But this one is difficult in core biopsies because you can sample the hepatocytic or hepatocellular carcinoma without sampling the cholangiocarcinoma component. So maybe the markers will be helpful. Tumor markers.
Thank you, Doctora. So a question was posted earlier by Dr. Judy. So schistosomiasis causes periportal fibrosis. Can it coexist with hepatic parenchymal fibrosis? I'm not too clear about the question. So again, the question is schistosomiasis causes periportal fibrosis. Can it coexist with hepatic parenchymal fibrosis?
Based on my current knowledge, I think it can coexist with hepatic parenchymal necrosis, fibrosis, because the schistosoma eggs, aside from deposition to the portal tracts, can also be found within the hepatocytes. So whenever this one occurs, it will incite granulomatous reaction or reactive changes such as deposition of fibrosis. So it can coexist with parenchymal fibrosis.
Okay. Thank you, Doctora. Any more questions from our remaining attendees? Okay. So again, if there's none, so let me again congratulate Dr. Mafe Bonifacio
so
for
much.
such extensive lecture, but easily I mean, I learned a lot, and I'm pretty sure it's the same with our attendees. So let me turn you over to Dr. Ome.
Yes, thank you very much for the very comprehensive lecture, Dr. Bonifacio. And also, thank you very much, Dr. Jamias, for moderating the session. And I would like again to thank everyone for joining us every Saturday afternoon over the last 6 weeks. And thank you to the Philippine Society of Abdominal Radiology and the Philippine Society of Pathologists for accepting our invitation to give lectures for our fellows and members through this webinar series. It has been a very educational 6 weeks, and we look forward to conducting more activities with your societies in the future. So again, before you completely leave the session, please click on the continue button and answer the survey so that you can also get your CME points after this. Again, thank you, and see you in future PSG CTP activities. Thank you and good evening.